Hello, good evening, good afternoon, good morning, and welcome. My name is Nurse Richard, the Wax Wizard. Welcome to episode 158. This was a massive removal, this one. It was monumental. There's a chap who came to see me earlier this week and had two ears, and they were both absolutely full front to back. Thanks for joining us on this episode. I think you're going to enjoy this one. The only channel where you get to hear the sounds as well as see the sights. So thanks to everybody who's followed recently. Hello to anybody new. Where have you been hiding? There's loads to catch up on. So this one here, it wasn't as difficult as the second one. The second one was really tricky because there was a really hard, dark, dense plug stuck to the eardrum. So you carry on watching to the end. You'll be able to see me having a right good battle with that one and a really good argument. Thanks for all the comments on the recent videos. I do try and I certainly read them all. It's not possible to reply to every single one. I'd literally be at it all day and all night. Look at that big chunk there. But thanks for the comments on some of the I'll put one on with some tales of my old job, a few funny stories. And a lot of people were quite interested in that, so I thought I'd share with you. Not necessarily a few stories, but there'll be a few stories in there. What a typical day looked like in my old job, which was a district nurse. Some people know them as a community nurse. Now, what's a community nurse? It's a nurse who usually works in the community and sees people, travels around, sees people in their own home, because these are people who are not necessarily ill enough that they need to be in hospital, but they have a long-term condition that needs support in their own home. So you can see dark, dense plug there right in front of the eardrum, gone down to the fine end to get that one up. So your average day can usually mean anywhere between 15 to 25 patients, which is a lot of pressure in that particular service at the moment. But an average day would start 8 o'clock-ish. And the first patients of the day would usually be diabetic patients who can't administer their own insulin. You might have 4, 5, 6 of them in a row, and no doubt the last one was saying, "What time do you call this?" I'm like, "Well, I've had another 4 to see here. I'm sorry, it is what it is. Can only be in one place at once." But the kind of problems that you can encounter. So, for example, the first visit, you get there, and these are all made up names. It would be Betty. Betty will be fast asleep in bed because she's the first one she's visited, not had a breakfast, blood sugars are in her boots, and when that's the case, you can't give her the insulin, so you've either got to quickly get her some breakfast, get something down her, check her blood sugar again, and if it's rise to a decent level, then you can give her the insulin. Or you've got to go away and do the others and then come back there later, so already you're a bit behind. And then the next one you might go to, they can't get to the door, something wrong with the leg, so you've got to go around the back of the house. I've climbed over fences, even sneaked through windows in the past, because you never quite know where somebody is. They might be on the floor behind the door. That's happened as well. And then one of the ones you could go to would be a care home. Now, I've been in care homes before, and first thing in the morning, the carers are all very busy. So getting people up, ready, dressed, showered, bathed, and what have you. Really hard to find anybody, and if it's somewhere you've not been before, and all you've got is a name, so right, I've come here to see Sonia, and you walk into the communal room, so right, which one's Sonia? And about 8 ladies put their hand up. I'm like, oh no, which one is it? You can't guess, obviously, when you're administering medication. So you finally find a carer, and then you find out which lady is the right one. Then after that, you usually see people who need medication through a tube or feeding tubes. A lot of people get fed overnight through tubes, usually coming straight through the stomach. It's people who've had problems with maybe the esophagus or the swallow. They've had a stroke, they can't swallow properly, but obviously still need nutrition. So you draw loads of medication up within syringes and administer it through this feeding tube. Actually did meet a fella who used to put alcohol and beer through his feeding tube in his stomach because he still liked getting drunk, but he didn't like the obviously couldn't taste it. He just put it in for the effect of getting a bit wasted. Fair play to him. I don't blame him, to be fair. God bless his soul. And then you'd start your routine visits, which could be literally caring for somebody in bed, somebody who's got a terminal condition, helping them to wash, dress. Then you might have some leg ulcers. I've seen leg ulcers that have got maggots crawling all over them. Sometimes you can smell them on the way into the house. They're particularly horrid. And the state of some of the houses, I've known some that have got like 20 odd cats in, and it smells something terrible. I've seen dog waste on the floor as well, and you're trying to do a clean, sterile dressing in amongst all this. This is the hard bit I was telling you about. I had a bit of a battle with this. Managed to turn it to the side, but it was really difficult to get out because when it flipped over, you'll see, I could only grab it with a leading edge, couldn't get a full seal. So then, yeah, you do some bandages, and some of these bandages, they're like 3, 4 or 5 layers, can take a long time to treat these leg ulcers. Then you might have pressure ulcers. I've seen some that you can literally stick your fist into and you can see people's bones at the bottom of the back inside. That's not uncommon, unfortunately. And then on top of all those, and your regular little plaster here, a little stitch removal here, removing clips from people when they've had knee surgery, hip surgery. It's the unplanned visits that were a right pain. You'd get a call saying, "No, the catheter's blocked. Got to go and change somebody's catheter." You get there, they've got no spare catheters. You're like, "Oh no, what do we do now?" Because it's a prescription-only item. If somebody didn't order one the last time they went in, you can't put a new one in, and this person's dying in agony because they've got a full bladder and it won't empty. So you manage to source one from somewhere. Occasionally that's been somebody else's house, so you just need to say somebody you know quite well, "Oh, please, can I just borrow one? I've got this patient up the road." "Yeah, absolutely fine, take one," you know. But then you might get another catheter call out, and I've known this to happen where it's a really large lady, and you get there, and when you get there you think, "I'm going to need some more hands here," because you might need another 2 assistants either side of the patient to be holding legs, so you can get in there, and some that you even need like a miner's torch on your head for, so you can see what you're doing. That has happened as well. Extra call-outs you get could be somebody who's got a terminal condition who needs some injections to keep them comfortable. That happens a lot. And we have to replenish things like syringe drivers. Now, what's a syringe driver? Now, it's a little machine, only about that big. You do have them in the hospital, but we have a version at home as well, where you fill up a medication, a large syringe full of lots of different medication to treat symptoms such as agitation, pain, nausea, and you fill it up, and then it takes a day for this syringe to slowly close. It's like going in through. It goes under the skin. It doesn't go into a vein, not like a drip. And that would be a typical day. And then after the end of that, you'd get your other insulins and your medication visits at the end of the day. People are like twice a day. You might get to Betty's house and Betty's not there. Like, "Where's Betty? Where's she gone? Where is she?" And you have to find a phone number of a relative, and the relative says, "Oh, I forgot to tell you, I've took her away for holiday." Like, "Did you take her insulin with her?" "Oh no, I forgot that." And you have to organise someone where she's gone on holiday to go and get, to find somebody where she's moved, to go and treat her over there. Honestly, it's a really difficult job. So if you ever come across any district nurses, please thank them, because they're very busy. They come across a lot of problems because people are different, and why shouldn't they be when they're being treated in their own homes rather than in hospital? When you're in hospital, the patients kind of have to follow the hospital routine, but when you're at home, people are more themselves, and sometimes that can lead to more problems. But I did enjoy that job. I did it for a very long time. I do miss bits of it. Most of it, no, to be honest, but I do miss bits of it. Anyway, I know I've been rambling on there, but I thought I'd give you a quick few stories and an example of what I used to do before I ended up doing this full time. Doing ears was part of what we did back then as well, but we stopped doing that. We were kind of made to stop doing that because it wasn't funded anymore. But anyway, that's another story for another video. But anyway, I hope you enjoyed this monumental one. But for now, take care of yourselves, and I will see you later. Bye-bye.